Discover the next level of critical care expertise with the Intensive Care Nutrition Fellowship, a phenomenal program for aspiring professionals in the field. With the increasing importance of nutrition in critical care, this fellowship fills a crucial void in training. It's not just a program, it's a deep dive into advanced clinical nutrition knowledge. The fellowship covers everything from basics to advanced concepts of nutrition for adults, children, and newborns, tackling questions about various critically ill patients across different specialties. This includes medical, surgical, cardiovascular, renal, hepatic, oncological, transplant patients, and more, encompassing both enteral and parenteral nutrition. Upon finishing, attendees will be capable of confidently and securely formulating nutrition plans and managing any related complications. Join the fellowship to reshape healthcare and transform your dedication to patient care into a leadership role in critical care nutrition. Whether you're a beginner or a seasoned professional, this program offers the perfect platform for growth. Your path to becoming a healthcare innovator is just a step away. Don't let this chance slip away. Embrace your future in critical care nutrition with the Intensive Care Nutrition Fellowship. Your journey to becoming a healthcare hero starts here.
Yeah, hello. Good evening, ladies and gentlemen. It's my pleasure to be with you today, and I hope the webinar will be of value for all of you. I believe this today is the last webinar in the Intensive Care Nutrition Fellowship, and I hope really you will enjoy it. And the journey was so long, actually, it's 1 year nearly around to pass. And I hope you will be a good ambassador for us in the coming batches of the fellowship. So let us to speak about fellowship today because I believe some of the audience are not actually belonging to the fellowship, so they might hear about the fellowship and then we're going to start after that. So Intensive Care Nutrition Fellowship is actually started as the first fellowship by the World Institute of Critical Care and Emergency Medicine, and we enjoyed a lot the preparation. So most of the people actually they are trying to help us to start the first fellowship by a program in the World Institute of Critical Care and Emergency Medicine. And we stayed maybe preparing for more than 1 year until we started in last July. So it belongs to the World Institute of Critical Care and Emergency Medicine. A lot of people helped us, including the instructors from all over the world. Dr. Amr Al-Husseini was the president of the World Institute of Critical Care and Emergency Medicine. We have a lot of people behind the scene, like Habiba from ICOM company and Buran and Maison and people arranging the platform like Iyad and people in the audiovisual like so a lot of people actually behind the scene helped us a lot to complete the fellowship without major problem. So it is actually a 1 year fellowship with the 3 modules, say 96 credit hours, and accredited by the American Association Academy. This is a certificate from the American Association Academy, and this is a module certificate, but when you finish the fellowship, you receive a new certificate called FWICN, so you can write in front of your name a title FWICN means that you have a fellowship of World Institute of Critical Care and Emergency Medicine in Critical Care Nutrition. So the three modules, the foundation of intensive care, module 1, module 2 will be thoroughly for the total parental nutrition, and module 3 about advanced critical care nutrition. Team model, actually, multi-speciality, intensivist, internist, endocrinologist, GI, physician, clinical dietitian, and the clinical pharmacist as well. And we have diversity of people coming from all over the world. Initially, we have the board members like me, Wafa, and Mireille, and we have Mona as a module lead, arranging actually the fellowship, like question and answers and like that, week by week throughout the whole year, and coordinating with engineer Iyad to have a nice, really, view of the fellowship throughout the year in the platform. And thanks really for Dalia. Also, we have significant speakers from all over the world, and we enjoyed really listening to their talks and their experience across all continents, from North America to actually Europe, and passing through Gulf area and India as well. We actually conducting every month a webinar before starting the fellowship and even after starting the fellowship, and webinar is free, so everybody can attend, not only the fellows. So this today webinar is part of this webinar, but I can show you a couple of webinars before. After webinar, we will have actually a certificate of attendance, and in the certificate attendance, you will actually have a very nice certificate containing the title of the webinar and the speakers. Registration is open, and with the webinar, we have 20% discount for the batch 2, which is going to start on July 7. I hope really to be with us. Otherwise, you will miss really the very nice fellowship over the year. So don't forget to enter webinar 20 to able to get 20% discount. Timing July 7, 2026. And now, before starting actually the fellowship, I would like to answer your question. If someone want any specific question about the batch 2 for the fellowship before starting to introduce Dr. Dua and Dr. Ismail. If you have really like an important question to ask, otherwise we can. So I believe Dr. Dua is with us now, so we can leave the question at the end. So it's my really pleasure to introduce the moderator helping me a lot throughout the fellowship, Dr. Ismail. He is a clinical nutrition consultant from Palestine. He's a clinical nutrition consultant from Palestine and president of Palestinian Dietetic Syndicate. Also is working in the Faculty of Medicine and Health Science, Palestinian Polytechnic University. I'm very happy really to have Dr. Ismail sharing me in moderating this kind of very nice webinar. Thanks, Dr. Ismail.
Thank you, Dr. Khalid. Thank you.
I have also Dr. Dua Ginina is very well known in the Middle East. She is Associate Professor of Nutrition and Public Health from Alexandria University. She is also practicing in Al-Amin International University في العلمين, and she's the head of clinical nutrition unit at Elite Hospital and president of the very nice association called the Egyptian Clinical Nutrition Physician Association. This is a unique association because there's a kind of nutrition specialist coming from physician background, which we love that. We know that we have a lot of dietitian expert in the field, and they're practicing, and they are suffering because they are always telling that doctors are not collaborating with us. They are thinking in different planets. So we'd like really to collaborate, and they understand the concept of nutrition, especially when you talk about critical care nutrition. And Dr. Da, when she organized this kind of association, she only involved the physician, which was really very great to educate physician in the field of nutrition. They can collaborate with the rest of the team in the multidisciplinary approach. I will leave now the floor to Dr. Dua, and at the end, we will come to questions and answers.
Well, Assalamu alaikum. It's really my honor and pleasure to join you today. Thank you, Professor Khalid and Professor Ismail, for chairing this session. And thank you all for being here. And actually, I'm very enthusiastic and happy to talk today about this debatable topic. And I would like to just tell you, Dr. Khalid, that we are already, as physicians, we are collaborating with all the partners in the team, including, and they are actually a pillar of the team, the dietitians. They are really doing a great job helping us in meal planning, monitoring the patient, educating the patient. And I think that all of us are doing this now in our practice. We are not just working alone. And now I'm going to share the presentation. Is it clear now?
Yes, clear, Doctor. Start.
Okay. So as I mentioned, our topic today is about enhancing the sepsis management. We are going to discuss the details through using a case study approach, and this is the agenda for today. Of course, before discussing the management in details, we should know a little bit details about the pathogenesis of sepsis. By the end of this presentation, the participants will be able to apply the current ASPEN or ASPEN and guidance for nutrition in sepsis, when and how to initiate the EN in the hemodynamically unstable patients, the rationale behind the underfeeding and autophagy, then when to decide to initiate the parenteral nutrition, finally to evaluate the evidence, or we are going just not to evaluate, but we will mention, do we really need to use the glutamine and the selenium, the antioxidants, vitamin C, the thiamine in our practice or not in these patients? These are the abbreviations reference. And this is our patient. Mr. Ahmed, 64 years old, he weighs 82 kilograms and his height is 173 centimeter, BMI 27.4. The patient had a history of type 2 diabetes, hypertension, COPD. He was an ex-smoker and not known malabsorption or GI disease. Before the illness, the patient was okay, independent, and he had no recent weight loss. And of course, this is very important for us because this is a sign of malnutrition, and because he didn't lose the management, yes, it will differ. As the patient is presented to the emergency department complaining of confusion, fever, the probable explanation for and the inflammatory response. The patient already had fever, as we know. The heart rate is at 122, tachycardia, and probably I'm going to think about the fever again, or maybe a sepsis, early shock, we'll see later to confirm the final diagnosis. The patient is hypotensive, and this is probably indicating circulatory failure, may be associated with the septic shock. The patient is tachypnic, indicating respiratory distress and maybe metabolic acidosis. Remember that he had a COPD. The peripheral capillary oxygen saturation was 86, and this is actually a moderate to severe hypoxemia, which could be consistent with sepsis-related respiratory failure or acute respiratory distress syndrome. Physical examination revealed that the patient is confused, lethargic. He had bilateral crackles and cool peripheries. All the previous vital signs which I mentioned with the physical examination strongly indicate an early septic shock requiring immediate resuscitation, infection control, and hemodynamic stabilization. You all know that sepsis and septic shock are associated with higher mortality in critically ill patients. The laboratory finding revealed high white blood cell count, indicating again or assuring the infection. The lactate was already high, 4.8, indicating lactic acidosis. C-reactive protein was high, confirming the inflammation. Creatinine was a little bit high, also 2.2, indicating acute kidney injury. ALT and AST was mildly elevated. The glucose, 266 milligram deciliter. So the patient had hyperglycemia, and remember that he was already diabetic. Regarding the pH, as you can see, 7.27, indicating the metabolic acidosis, which most likely be due to the lactic acidosis from the septic shock. The main cause could be the poor perfusion, the tissue hypoxia, and the impaired renal function. Regarding the preserved the peripheral pressure of oxygen and the FiO, we had a number of 140. This is very important, significant, indicating the significant impairment of the oxygen exchange, the moderate acute respiratory distress syndrome, and this is also likely due to the sepsis-induced lung injury, pneumonia, and the inflammatory capillary leak. Albumin was 2.5. Does this indicating the presence of malnutrition? What do you think? So can we interact through the presentation, or Dr. Khalid or Dr. Ismail? Hello?
Yes, Doctor. Yes, Dr. Dua. How are you?
So what do you think? How are you, Dr. Ismail? Pleasure meeting you. كل سنة وانت طيبين.
وانت طيبة.
They actually sending questions in the Q&A box here.
But now I'm asking them, do you think that the albumin here, 2.5, is indicating malnutrition?
Yes, good question, والله دكتورة. Yes.
So what do you think? Anyone can answer this question?
I don't know if we can answer, if I can answer.
Okay.
We have Sarah, Amina, and all of them said no, not an indication for malnutrition.
Perfect.
It is an acute, can be decrease in acute illness or like that.
This is absolutely true. The problem is, until now, we face this every day in the critical care unit and in hospital in general. Still, the physician is asking for albumin and albumin only and deciding according to this number that the patient is in need to albumin replacement. I think you face this, you face it, Dr. Khalid, too, in your hospital. Unfortunately,
definitely.
Yeah, until now, although that we all know that the albumin is a negative acute phase reactant, actually it is a marker of disease severity, representing the acute inflammation, not malnutrition. So it is not a reliable indicator of nutritional status in acute illness, but it may predict the higher fluid requirements may be needed and the edema risk as well as the potential delayed recovery. So please do not use it ever as a malnutrition marker. The last three abnormalities together indicate that indicate a case of sepsis with severe organ dysfunction, the acidemia, as I said, the moderate acute respiratory distress syndrome, as well the intense inflammation and capillary leak proven by the low albumin level. And this profile reinforces that this patient is in a high risk hypercatabolic phase. X-ray was done and it revealed the bilateral infiltrates, possible pneumonia, and the diagnosis finally was done sepsis with septic shock from the presumed pneumonia with early acute respiratory distress syndrome. And again, alhamdulillah that the patient is not severely malnourished. As I mentioned, he didn't, the weight was stable. He didn't lose any weight before admission to the hospital, but he is in a hypercatabolic state due to sepsis. Back to pathophysiology. We have to know that sepsis is a life-threatening organ dysfunction, which is caused by a dysregulated host response to infection. Why it is important? Because the incidence is as high as 1 to 2% of all hospitalized patients, and it is one of the major causes of death in critically ill patients worldwide. So we should consider it. We should also differentiate between the sepsis and the septic shock. And according to the third international consensus definition for sepsis and septic shock, septic 3, to decide that this patient had a septic shock, which is a subset of sepsis, it is defined by the persistent hypotension requiring vasopressors to maintain the blood pressure despite adequate volume resuscitation, and we should have a high lactate level above 2 millimole per liter, which is a sign of poor tissue perfusion. Accordingly, this case is a life-threatening condition associated with severe infection leading to widespread cellular and metabolic abnormalities. What was done for this patient within the first 24 to 48 hours of admission? We started, طبعا not me, the team, the intensivist started the fluid resuscitation, giving 30 ml per kg. Vasopressors was started by norepinephrine. Antibiotics were administered, broad-spectrum antibiotic. Also, the mechanical ventilation started to protect the lung with stress ulcer prophylaxis and deep venous thrombosis prophylaxis. Everything was okay. After 2 days, the patient still on norepinephrine, but dose was decreasing, alhamdulillah. The mean arterial pressure was between 68 to 72, and there was no evidence of active GI intolerance or bleeding. The abdomen was soft. Gastric residual volume was 180 milli every 6 hours, and urine output was improving. The intensivist consulted the nutrition support team in day 2 in the ICU, and this was the assessment summary. Patient in early septic shock, hemodynamically improving, in a high catabolic state, no contraindication to or cautious to start enteral nutrition. The patient is at risk of he's already was hyperglycemic and still at risk of hyperglycemia, and the labs indicate inflammatory status, as you've all seen, with the low albumin, which is not again a nutrition marker, and the patient was not severely malnourished prior to admission. So my question to you, should you start the enteral feeding now? And if yes or no, Why or why not? And I think for the sake of time, I'm going to answer the question myself. But first of all, I have to remind you that Mr. Ahmed is now on decreasing vasopressor support. Mean arterial pressure was above 65, no abdominal distension. Why do I have to mention the mean arterial pressure? Because this number indicates sufficient blood flow to supply oxygen and nutrient to body vital organs, good perfusion. So this may help me in deciding when to start the feeding. But again, back to the pathogenesis of sepsis, it is actually extremely complex. A series of events, inflammatory responses, disturbed immune dysfunction, mitochondrial damage, increased coagulopathy, neuroendocrine network abnormalities, stressed endoplasmic reticulum leading to unfolded protein response, the autophagy. And this is actually the clue which will give us will clarify the road about when to start and when to take the decision. Eventually, all these sequences will lead to organ dysfunction. What is autophagy? Autophagy refers to a natural process by which a cytoplasmic substance or pathogen. So from this sentence, I can understand that autophagy is not bad. Actually, this is a good response, which is engulfed by autophagosome, which is then fused with a lysosome to be degraded. This is critically for the mitochondrial, enhancing the mitochondrial quality and for the removal of the inflammagens and pathogens. So this will clear the damaged protein, organelles, and pathogens. And this is essential for the host pathogen defense and the immune surveillance. So this is actually good. This will enhance the situation, not deteriorating it. It's like the acute phase reactant reaction. So imagine that you are going to stop the autophagy if you are going to take a wrong decision by delivering the feeding in the wrong time. This is the first step. Secondly, in the acute catabolic response, as you all know, the early catabolic response, the EPB phase of critical illness, the rapid mobilization of energy stores, muscle, glycogen, lipid stores are actually broken down to drive the glucose production in this early period of critical illness. This response actually may generate up to from 50 to 75 of the glucose needs during the illness, and it is not suppressed by feeding or any intravenous glucose infusion. This is what we call the conserved stress response, allowing the septic patient to generate energy to escape an attacker and then recover from the initial illness in a period where food gathering and consumption would initially be limited, especially if the patient is unstable. So the conserved stress response is upregulated by a range of cellular stressors, including fasting, various pro-inflammatory signals. So this catabolic process may be dynamically reproposed to resolve the cellular stresses that may emerge during sepsis. So again, this is explain why autophagy is important. So to feed or not to feed. Another important confusing point here that the rapid loss of lean body mass contributing to wasting, weakness, and loss of the physical function due to the ICU acquired weakness or the post-ICU syndrome should be an issue for us. So sometimes we rush by giving a high amount or to start feeding early, focusing whether using the maximum protein intake or not. Like, and still here we should think or consider I should start the feeding to prevent the catabolism. The metabolic response rely heavily, mainly at the beginning, on the patient's nutritional resources, intense endogenous production of energy substrate, which requires adequate nutritional intake. So this is important in patients starting with malnutrition or at a high risk for malnutrition before the admission to critical care. But in our patient, this is not the case. I said that the patient didn't lose weight and he had catabolism, but he had not yet entered into malnutrition. We know that the stress-related increased metabolic needs are likely to promote malnutrition or aggravate pre-existing malnutrition at the time of admission to critical care. So the malnutrition is associated with impaired clinical outcomes. And again, we are going now to be confused. Are we going to start or not? A main point is the nutritional status on admission. If the patient was malnourished or not. So to start the management, we should consider that we are not going to work alone, but the current treatment for sepsis are focusing on the conservative strategies and using antibiotics and hemodynamic support, which is going to be handled by the intensivist, as well as the fluid resuscitation, the MDT, as Dr. Khalid mentioned. But still, the nutrition will play a crucial role in management of sepsis. Adequate nutrition can help improve the immune response, reduce the inflammation, and promote tissue repair. So the question now that I asked before and should be answered based on the knowledge that we just revised together in the previous slides. When should the nutrition be initiated for this patient? Again, it is still challenging. Why challenging? And looking for the available guidelines, whether the Aspen Surviving Sepsis campaign, look to the guidelines now. When the Aspen recommend that we propose the initiation within 24 to 48 hours after diagnosis of sepsis in hemodynamically stable patients. While the Surviving Sepsis campaign just encourage the progressive feeding throughout the first week of ICU stay with a low to moderate quality evidence. Aspen recommend the first 3 to 4 days after ICU admission to start the plan in hemodynamically stable, with sepsis excluding those in shock, and this is based on the expert consensus. And Bardo, you know that we usually use the evidence and the grading criteria to say if this is mandatory or this is the lowest is using the expert consensus. So from this, we can say that the current guidelines show a lack of clear evidence for the nutritional support efficacy, and the details about when to start, what to give, how flow are still, we have a lack of evidence to stay to start the answer, but to say what is the best timing, but it should be tailored according to the patient progression and the shared decision making by the intensivist and the nutrition team. So what feeding strategy is the most appropriate in the first week of sepsis? Choose the best option from these. Shall we start the full calorie enteral nutrition to match 100% estimated needs, or hypocaloric EN providing 40 to 60 of estimated energy, or to start the parenteral nutrition because EN may worsen the gut hypoperfusion, or to start full protein immunonutrition immediately. Actually, based on the ESPEN guidelines, the early R and progressive EN should be used in these patients after stabilization. But if contraindicated, EN should be replaced or supplemented by progressive parenteral nutrition. Why EN? Because we all know that the enteral nutrition is crucial for the preservation of the gut integrity and intestinal permeability to already prevent the bacterial translocation and to avoid sepsis. Additionally, but now the patient is already in sepsis. We know that. And again, the enteral nutrition is not only for this part. It plays a major role in down modulation of the inflammatory response and insulin resistance. So that's why we know in critical care general nutrition guidelines that EN should be the first choice for the nutritional support. As we mentioned, we can start the first 3 to 4 days after admission in order to avoid the overfeeding, especially in the hemodynamically stable patient with sepsis or those with decreasing vasopressor doses. The gold standard to estimate the patient required total energy, of course, is the indirect calorimetry, which is not available in many hospital settings. I don't think we have any hospital in Egypt using the indirect calorimetry, and I believe most of you also. So we have to use the predictive equation. These are the options that we can rely on in calculating the estimated energy requirement of our patient. Using the equation, we usually recommend the hypocaloric feeding below 70% of the estimated need, and it is the preferred over the isocaloric nutrition for the first week of the ICU stay. طبعا we give 20 to 50 or to give 20 to 50% of the full nutrition support, mainly to open the enteral route. Then amounts should be progressively increased according to the GI tolerance. We never start with the 70%. And in septic shock, mainly due to bowel ischemia, so you should take care. The impaired splanchnic perfusion can further aggravated by the enteral nutrition administration. So in this case, we are going to delay the enteral nutrition. This is all confusing points. That's why it is challenging. But remember that the impairment of the gut barrier function and the dysregulation of the immune system will make the septic patient more susceptible to immunosuppression, secondary infection, and exacerbated systemic inflammation. So taking the decision will be difficult, like maybe targeting the gut is a breakthrough in elevating the condition of sepsis patients. Why we are saying that? Because in many centers until now, the MPO practice and for any septic patient, so the decision could be taken not only for 2 days or 48 hours or even 3 days. The patient could stay up to 5 or 6 days without nutrition. So take care. Or in some other centers, they may start immediately the parenteral nutrition without thinking, ignoring completely the enteral nutrition. So no, please discuss with them this point carefully. We are not going to rush, but we are going to consider the enteral nutrition whenever possible, just to target our gut and to maintain the integrity and elevate the condition of sepsis in general, not worsening it as they sought. Are we going to use the gastric residual volume to start and to monitor our nutrition support plan? According to the guidelines, please, we can use it for the GI dysfunction assessment to identify intolerance, maybe only during the first step of initiation, but it is not يعني encouraged anymore to use it for the to monitor our established plan only for initiation. This is by ESPEN. They suggest that enteral feeding could be delayed when the gastric residual volume is above 500 ml every 6 hours, but not to monitor, as I said. And in some other guidelines, they do not recommend using the gastric residual volume at all, just depending on the signs and symptoms of overfeeding, including distension, abdominal distension, rigid abdomen, or some vomiting or something like that, to stop or to regret, to go back a little bit in the volume or whatever, but do not depend on it anymore. If the examination of abdomen does not suggest an acute abdominal complication, the ASPEN and the Surviving Sepsis Initiative recommend using prokinetics instead of stopping the feeding. And you know that you can use the metoclopramide, although the extrapyramidal manifestation, which may happen, but not all the places administer the erythromycin. These are the common two choices which we use. If we are going to start the metoclopramide, we will use the 10 milligram 3 to 4 times a day before meal. And if the erythromycin, this is the recommended dose, 3 to 7 milligram per kg per day in case of feeding intolerance. As I said, instead of stopping the feeding completely or rushing to the parenteral route. And of course, if the enteral nutrition is not feasible or insufficient after 3 days, then parenteral nutrition can be prescribed. The amount should be half of the predicted or measured energy needs, and the enteral nutrition should be prescribed or resumed as soon as the clinical condition permits. Until now, the best timing to prescribe supplemental parenteral nutrition still debated, and it is suggested to be between day 4 and day 7. Still, we are talking about when to initiate the nutritional support. In all cases, overfeeding should be avoided. First 2 days, it's better not to start the oral or the nutrition support, not to stop the autophagy. This is a protective mechanism. We should keep it for the first 2 days and then start the feeding gradually, and overfeeding by all means should be avoided. It's going to add, especially in the acute phase, it's going to add to the endogenous energy production, which amounts about to 500 to 1,400 kilocalorie, leading to delirious effect. Hospital stay will be prolonged, the ventilation duration will be prolonged, the infection rates will be higher, as well as the risk of overfeeding. So تاني, again and again, a too low intake, but consider that too low intake also below 50% was associated in retrospective studies with worse clinical outcome, and this may lead to severe caloric debt and empty our energy, the patient energy reserves, will reduce lean body mass and may increase infectious complication. So cautiously consider the endogenous energy production and add on it, and progressively increase the recommended energy, total energy and protein, do not rush and do not stay for long after the first week of admission in the flow. After the flow phase, do not stay long below the recommended to prevent worsening the clinical outcome. In sepsis, the GI shutdown occurring in the acute phase likely reflects a strategic energy conserving immune adaptation, which is good with autophagy, but we have to know the terminology or the definition of these three feedings: hypocaloric nutrition, trophic feeding, and permissive underfeeding. Which one are we going to use in our patients, our patient with sepsis? Hypocaloric nutrition is the intentional means that we intentionally delivers less non-protein nutrient, but giving the full protein intake, recommended intake, then would be required for the total daily energy expenditure. The trophic feeding is feeding at a rate of under 500 kilocalories throughout the total day, focusing mainly on maintaining the gut integrity. While the permissive feeding, underfeeding, means that we are going to feed totally under 40 to 60% of the total calories required for the daily energy expenditure, including the recommended protein intake. The intention permissive underfeeding is to intentionally provide less nutrition, not only non-protein nutrients. According to the recent guidelines, it is the permissive underfeeding is a solution that balances the benefit of nutritional support with adverse effect of overfeeding during the early stage of ICU admission. So this one is the recommended strategy to be used. And the rationale again is to preserve the beneficial, very important, beneficial catabolic state in the early or phase in sepsis, and the early full nutrition support may impair this process, including the autophagy, and lead to harmful effect. Initiating the early parenteral nutrition has even been has been associated with determinal effects in some large clinical trials. So throughout the presentation, we stressed on this critical period that we should maintain this normal response occurring in the early phase or the early state, early admission in sepsis. In this acute phase, we should preserve this catabolic phase. Do not start with enteral and or even parenteral supplementary nutrition. So the correct answer would be, according to our understanding, because there is no clear recommendation about what to use, the answer would be the hypocaloric nutrition and the permissive underfeeding, using the ESPEN guideline here, 20 to 50% of the target initially and then increase progressively. This is I'm just reminding you here with our patient Ahmed that he was on decreasing vasopressor support. He was okay regarding the mean arterial pressure, and there was no abdominal distension. For our patient, are we going to start the enteral? Why? And this is the answer of the question, why or why not? We are going to initiate the enteral nutrition for our patient within 24 to 48 hours. This is the first choice of support, as you all know. And this actually meets the ASPEN and the ASPEN criteria together. We are going to start early but cautiously, and if this is not feasible or insufficient, after 3 days we are going to start the supplementary parenteral nutrition, and using 50% of the predicted or measured energy needs, we are going to avoid initiating the earlier PN. Please do not start earlier according to the available guidelines. Regarding the protein intake until now is debatable again, and we have no correct answer. The evidence is weak. No consensus for the high protein early start. You can start with moderate protein intake and advance gradually. Why? Because we want to avoid, again, the risk of autophagy suppression. We need still, until now, we need most of the guidelines recommend that we need more well-conducted randomized clinical trials to answer the question of the best timing and the dose of protein administration in ICU. Shall we use glutamine supplementation for this patient? Yes or no? Can we interact again? Still we have time. We are not late. Shall we use glutamine? Any opinions? Hello?
Amina said if required. How we
So what is
how we decide it is required?
If it is required, yes, a very nice question. How can we decide that it is required, Amina? Okay, let me answer. No, the answer is no. In sepsis and septic shock and the multi-organ failure risk, do not use glutamine supplementation. It will, based on a very famous study published before, a higher glutamine supplementation may increases the it increases the mortality in septic ICU patients. So please, it is not recommended. So shall we consider adding selenium or antioxidants to improve the outcome? And because we know that septic shock and high oxidative stress selenium may help as a potent antioxidant. So do you think that this will add something to our patient? Amina, what do you think here?
What about selenium? What about selenium as antioxidant here? No.
Based on your practice, if anyone practicing, or you should not, maybe you don't know the correct answer, but do you see this in your practice? Physicians are prescribing the selenium to improve outcome?
No.
It is not recommended.
Yes.
No mortality benefit, or even may carry mixed or harmful evidence, harmful effect, and this is proven by evidence. It may shorten the shock duration, but does not improve the outcomes. So actually, it is not recommended. Vitamin C, the famous vitamin C, the arginine or omega-3. We have no sufficient evidence until now for the routine use in sepsis. Regarding the arginine, actually, it may raise the risk of hemodynamic instability, so it is not recommended. And for omega-3, we have weak evidence and no clear benefit. And that may help. It may help in in enhancing the acute respiratory distress syndrome, but it is not recommended for sepsis. What about the PN? When are we going? When should we start supplementation, parenteral nutrition, if EN is inadequate? For Ahmed, Mr. Ahmed, on day 5, he was tolerating only 30% of energy needs by enteral nutrition. So now I think that we said that we can start the parenteral nutrition from day 3 or the day 4 to 7 according to the guidelines based on the ESPEN guidelines. And because Mr. Ahmed didn't achieve or tolerate only 30%, so we are going to start supplementary parenteral nutrition on day 5, low dose parenteral supplementary only, not full dose. Back to the guidelines here, you can see that the guidelines of the ESPEN. Early and progressive PN can be provided instead of non-nutrition in case only a contraindication for early enteral nutrition in severely malnourished patient, which is not our patient. Now, sorry? The initiation of the low-dose parenteral nutrition should be carefully considered and balanced against the risk of overfeeding and refeeding, which may outweigh the expected benefit. They are still confusing us to give or not to give, but this is a clinical decision on site, taking in consideration all the circumstances, the clinical picture, the monitoring, the laboratory output, which is usually done every day, monitoring the intake of the patient and the general condition, the vital signs. Accordingly, we will decide, are we going to start? The patient is improving, he's okay, but not tolerating more than the 30%, as I mentioned. So we decide now to start gradual supplementary parenteral nutrition. The recommendations are weak until now. The issued recommendations were weak because we have low quality of evidence, and most of them finally are based on expert opinion. So my conclusion that the current guidelines show a lack of clear evidence for nutritional support efficacy, prompting the need for high quality trials until now. And I remind you that the gastrointestinal shutdown are not passive, but they are adaptive, so do not rush. This shutdown promote catabolism, autophagy, enhance the cellular survival and immune function. The nutritional support should consider the timing, the time, and the physiological context and shared decision making. The nutritional program for these patients should be tailored and must always be preceded by a thorough nutritional assessment, not by what are the guidelines saying. Close monitoring is required to again adjust the program according to the metabolic change and resumption of oral feeding and stability, of course, and the MDT is crucial. I like this slide. I made it using the notebook AI program, summarizing the recent guidelines from 2024 to 2026 regarding the sepsis nutrition plan algorithm. This is the summary of the pathway. Starting the resuscitation is mandatory hour 0 to hour 24, using the the fluids طبعا, resuscitation, the vasopresses, as I said. During this time, please, zero nutrition to preserve the autophagy and the physiological body response, which is beneficial, or the GI shutdown, which is beneficial for the patient. In the early acute phase, day 1 to 3, you may start your nutritional plan, but use only the gastric residual volume for the initiation, not for monitoring. Use the prokinetics if needed. The target look, the permissive feeding, as I said, the hypocaloric, include low protein, low calories. The target will be 12 to 15 kilocalories per kg per day, and the protein intake recommended 0.8, 1.2 gram per kg per day. Start with the lower range, then increase gradually. This is the ABB phase. Start in the flow phase, starting from day 4 to day 7, which is the late acute phase. Escalate your target, reaching the 25 kilocalorie per kg at the end of the 7 days, and the target protein intake, which is 2 gram per kg protein. طبعا, if the patient is at a high risk of or was at a high risk severe of malnutrition, using the Nutric score, if it is above 5 and the patient didn't reach the target, in less than 60% of the total recommended intake in the late acute phase, you can add now the supplementary parenteral nutrition. The main 2 nutrients here, micronutrients, should be considered, not vitamin C, not selenium, it's the thiamine. لأنه طبعا many patients could be at risk of refeeding syndrome during this period. So thiamine is very important. We usually give it the first 3 days with our plan, as I mentioned, to avoid the risk of overfeeding. Importantly, to consider the vitamin D nutrition, the vitamin D supplementation due to its immunomodulatory effect, important in sepsis, especially if the patient was already suffering from deficiency before starting or before hospital admission. I hope this slide summarized our plan. And because we don't have that much time to go into details, I was trying to give a short hint about nutrition during sepsis, focusing on the main outcomes that I need you to go out, the take-home message, that do not rush, consider a gradual escalation, consider the medical team, the MDT, in taking the decision. Do not fight, argue with the evidence all the time, and give time for taking the correct decision with all the team, not to do any mistake. And then you will take the responsibility at the end. We have now in Egypt what we call المسؤولية الطبية, and you are going to be asked to justify why every single details in the plan. So be in the safe side. Do not rush. The guidelines are changing. They started by start early, then give the maximum at the beginning. We want to avoid malnutrition. We want to do the best for our patients. But again, they are coming back to say, no, do not rush. Start gradually. Thank you very much. I finished now my presentation and waiting for the discussion.
Yeah, thank you, Dr. Dua. It was great, really, presentation. You summarized everything, and you're including all aspects of guidelines, including macro and macronutrient as well. And thanks, really, you touched base on vitamin D as well as the thiamine, which is usually people are forgetting it while managing critical ill patients. And for example, I can tell you that I have seen many patients lactic acidosis will never improve without prescribing thiamine. So you don't forget the value of micronutrient as well as macronutrient. I will leave Dr. Ismail to handle the question and answer, and please stay with us.
Okay, thank you very much, Dr. Dua, for your nice, fantastic. You put the science into practice in your presentation. This is great, really. Thank you a lot. Now
You're most welcome.
we have some questions here. Abdul Hamid asking which yes, he asking so that about which prokinetics. I think Dr. Dua, you mentioned the prokinetics that will be given in.
Metoclopramide. Actually, we are using the metoclopramide.
Yeah.
We don't have the erythromycin, the one recommended doses in IV or something like that. So we usually use the metoclopramide under observation to prevent the major complications, which are mainly extrapyramidal manifestations. So you have the patient should be closely monitored, and we should not give it for a long time, not more than 4 to 5 days.
Yes. There's another question. What if patient kept on hemodynamically unstable for 7 days? Do we consider initial feeding to avoid malnutrition, or we have to wait more?
Okay, Dr. Ismail, would you repeat the question? I didn't hear the first part.
If we have a patient, he is hemodynamically unstable.
The patient is unstable.
Yes, for 7 days.
For 7 days.
Yes.
Okay.
Can we initiate feeding or avoid till he is hemodynamically stable?
Well, thank you very much for this excellent question. And I think Dr. Khalid will share with me we need the input of Dr. Khalid too. Regarding the guidelines, we don't have a straight answer in this case, but what I'm going to tell you, even from the practice and after carefully assessing the patient with the intensivist, if this patient is improving and he is taking the dose of the vasopressors and norepinephrine is going down and decreasing, so now we can consider trophic feeding only. We can start with trophic feeding to assess. But if the dose is still very high, I don't think I am going to start the feeding. If they cannot resuscitate the patient, so they will postpone the nutrition. I think they will just depend on the fluid resuscitation, and some of them give protein IV, but they don't refer the patient to us as Mr. Ahmed, which I discussed it here. Dr. Khalid, please, your input.
Yeah, I agree with you 100%. If the patient is hemodynamically unstable, the priority first to resuscitate the patient. And once the patient adequately resuscitated, even if he's in vasopressor, we can start feed him like initially trophic feed with thiamine, and then gradually will go up. If there is no harm and lactate is coming down, we have cutoff of lactate of 4. Anything above 4, we should not feed the patient. And the new guidelines in 2025-26, they specify the amount of vasopressor who is actually safe to feed the patient, which is 12 microgram per minute of norepinephrine. So anything above 12, the patient considers very unstable to feed him. And we're always telling that any metabolically unstable patient, we should not feed him whether parenterally or enterally. So metabolic instability is the cause, not of the hemodynamic or not hemodynamic.
Perfect. Perfect answer. And you add a lot by this, by specifying now the dose of vasopressors. This is amazing.
Dr. Da, I have a question because there is no questions in the Q&A. What about the using of intralipid or dextrose when we are starting parenteral nutrition with enteral when the patient is receiving only less than 50% of his requirements, and we decide to put him in a parenteral nutrition to support.
Okay. So what is the question that we are going to use?
The question,
Of course,
what about the use of
avoid
intralip? The
avoid
intralip,
the soy-based. Dr.
yes.
Khalid Malik, يعني the king of this lecture,
Yes.
use always that one with the omega-3 based or mixed base, not the soy.
Yes.
But احنا يعني in my practice, I usually use the bag, the 3-in-1 bag,
Yes.
the small one, the 800 calories only bag as a supplementary. I don't compound. I don't use the
Okay.
line
Yeah.
alone fat, alone protein. I
Yes.
prefer to use the bag 3-in-1 actually. يعني.
3-in-1. Yes.
Khalid, his own input would be appreciated.
I agree with Dr. Ismail, with you, that there is no contraindication to start lipid from the start unless there is hypertriglyceridemia, pancreatitis issue, a severe liver disease. But any other patient, the standard to start the 3-in-1 as a ready to hang, or if you have a compounding, will be fine. But even when you have a compounding, we are trying to use the ready to hang formula. Unless patient is complicated and has multi-system problem. So make it like life easy.
Thank you, Dr. Khalid. Another question from Fureha. She asks, sometimes we use arginine in ICU patient as part of the immunonutrition formula. So it is not recommended for all ICU patient, or it is recommended for all?
لا طبعا it's not recommended for all ICU patient. The
Yeah.
immunonutrition formula, including the
Arginine.
arginine, nucleotides, omega-3, are helpful. We can use it in trauma patient, we can use it in burn patient, but not for all. It's not recommended. We don't have evidence that this is the best choice for all patients. You can use the standard formula, but in these patients specifically and the surgical patient, you can use also the immunonutrition formula.
Another question about the use of aspirin, or if the dose is above 4. I think it is covered by Dr. Khalid and by you, Dr. Dua. In previous lecture, Dr. Khalid talked a lot about the aspirin. So if we are lactate above 4, we should not start enteral or parenteral. Talking about the level of aspirin dose. Lactate, lactate level above 4.
Lactate
Yes,
above 4
lactate.
زي ما
Yes.
Khalid has mentioned now.
Yes.
She's asking about the feeding, if the lactate only above 4.
Yeah, lactate above 4. We should not start. She asked, we should not start.
But we don't. Are we going to depend only on the lactate?
I don't
One
think
of the parameters. No.
Aspirin and lactate. Lactate, I think it's not a determinant indicator for the use
Yes,
of
it's not
feed the
indicator
patient.
for
Yes.
starting the nutritional support plan, but it's an important one considering all the other
yes, as
details.
part of,
yes, lactic
yes.
acidosis and the kidney, and assessing all the laboratory profile altogether, not only focusing on this number.
Okay, I think the last question here talking about oral feeding. I think a patient at ICU, when he starts or he's able to use oral feeding, I think we succeed. What's your opinion, Dr. Dua, about oral feeding?
Of course,
the patient is now
if
alert
the
and
patient,
oriented.
If the patient is alert and oriented, so the first route of feeding is oral feeding.
Yeah.
Of course, the first choice should be the oral feeding. But in this septic and patient with septic shock or sepsis, usually are confused. They have confusion, or they are not in a good status to start oral feeding. But if your patient is ready, of course, start the oral, first choice. If not, then we think about the nutrition support using the nasogastric tube. And as you know, the criteria, if we are going to stay for a long time with the nasogastric tube, we should think further to use, especially for not the critical ill patient only, but the patient for 28 days with the nasogastric. Now you should consider the gastrostomy.
Yes.
And if the gastrostomy, the patient is a high risk of aspiration, or not, this is not a suitable route, then we go for jejunostomy post pyloric, right? And at the end, if all this failed, then we'll think about the parenteral. This is the normal sequence. Oral is number one, as long that the patient is tolerating.
At my hospital, Dr. Dua, we usually start or just try to give oral feeding even the nasogastric tube is inserted. Is it right?
Sometimes. Sometimes we do that. Yes, we mix. The main bulk will go through the nasogastric, but we will start, if the patient is willing, to give him something with the oral route. No problem.
Yes, thank you. Thank you. What Dr. Khalid? There is no question now.
Okay, that's great.
Here, someone from Palestine asking about immunonutrition formulas in Palestine. Yes, it is presented, but maybe not as commonly used in public hospitals, in certain private hospitals. Yes, we have. He asking in Palestine about the immunonutrition formulas. Yes, we can find it, but not. Usually it's not used in governmental hospitals, but it is presented. We can find it.
But this is everywhere, Dr. Ismail, not only you, and not all places. Usually we suffer to have the basics in the governmental hospitals. It's not available everywhere.
Yes. Thank you, Dr. Dua. Thank you very much. Thank you a lot for your real amazing presentation. And it is a good idea to start with a case and to follow it. That's great that you apply the science on a real case, or very 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 fantastic حقيقة. أشكرك دكتورة، شكرا كثير.
Thank you,
Khalid.
thanks Dr. Ismail, thanks Dr. Dua for the amazing lecture, and thanks Dr. Ismail for your kind moderation of the lecture, and thanks for the fellow attended and people attended outside the fellowship. And I advise everyone who actually did not share in the fellowship should actually register for the batch 2. Would be great. And for the fellows, we actually came to the end. This is the last webinar. And also still we have last week about food drug interaction. Next week it is not a webinar, but it's a regular week in the fellowship. Then our exam will be in June 8th. Will be actually starting at 8 o'clock from June 8. We'll stay for 96 hours. When you open the exam, it will stay for 60 minutes. It's a 50 question multiple choice. Only one best answer to be chosen. So please, the people who are actually candidate to enter the exam, who actually finalize his task, so the module 3. So please just be sure that you finalize your task in module 3 to be eligible to appear for the exam.
Dr. Khalid, excuse me if I can talk in Arabic for our colleagues in Palestine. I think there are a lot here with us with this webinar. Really, we recommend to join the fellowships that you are introduced to them, because I think this is one of the most important methods that they can improve their career abilities, and so become up to date to the scientific and recommendations all over the world. So it is really recommended, because this will improve their professional in the very important major topic and major field of the clinical nutrition when we are dealing with ICU patients. So thank you a lot for everything, and they have a chance to take a promo discount, and anyone who is interested, he can talk to me, and we will help so as to be registered and to take the fellowships you are usually plan to do. Thank you, Dr. Khalid. Thank you, Dr. Dua. Thank you, everyone.
ثانك
Thank
يو،
you.
كل سنة وحضراتكم طيبين.
وانتم طيب،
طيب.
كل عام
عيد
وانتم بخير.
سعيد إن شاء الله، كل عام
إن-
وأنتم بخير.
ان
إن
شاء
شاء
الله.
الله عيد سعيد عليكم كله. أشوفكم على خير.
Thank you.
شكرا. سؤال.
باي باي. Have a lovely
Bye.
night. باي باي.
Bye.
Thank you. Bye.